Services Board. Welcome everyone. We do have a quorum. Just bear. Look at the agenda. Any questions about the agenda? Any additions or? If not, we'll just accept it as it is presented. Look at the board minutes. We've seen them by internet. Any questions, discussions about the board minutes? If not, do I have a motion that we accept the May 2014 board minutes as presented?
So moved.
Second.
Second. Any questions? All those in favor say aye.
Aye.
Great. Jim? Thank you.
Good afternoon. In your packet or on your iPad are the financials for the month ending May 31st, 2014. We are now 91 2/3% through the fiscal year. 1 month to go, but we're in right now, and we're finishing strong and able to meet all of our mandates and be able to fulfill the mission and the vision that you helped establish for us for FY14. We look first at the expenditures report for DSS. You'll see that we're right on track based on where we were this time last year and also where we should be at this point in the fiscal year. Just to point out the things that we've talked about before related to capital expenditures. That was a one-time expense that was placed to us for the building at Cox Avenue, and everything else is within budget. Where you'll see where we're it appears that we're over is in aging services, and those are because of contracts that we do with the Land of Sky Regional Council for the administration of aging services for us. Other than that, we're right on track with where we should be at this point in the year. Do you have any questions about the DSS portion of the expenditure budget? And then we'll look at public health next. And again, you'll see the same area where we were. We're 91 2/3% through the fiscal year, and you'll see the same area on contracts. And again, that's the same expenditure that I talked about before was a result of a depreciation amount that was put into our capital line by the county, and that was been done several months ago. I do want to point out one thing that you may notice where it says contracts, and it says, wow, we're just really not spending any of our contracts. The majority of those dollars represent our contract with Western North Carolina Community Health for the prenatal, and we pay that once a year, and we pay that in June. So you'll see that percentage go up in the next June report. Otherwise, we're right on track of where we need to be in our spending, and I'm happy to answer any questions that you might have about health expenditures. Just as a point of clarification, next month will be, in July, we will not be reporting out on our financials for June because of the year end. We'll still be open and we'll still be accepting expenditures, and we'll be able to have a final report for you at the August board meeting. We are doing projections and sending those to the county, and we will meet our budget and stay within budget. And I think, again, we hit a strong finish to this current fiscal year. Any questions about the financials?
15, FY15.
FY15, we are now in an interim budget. You may have seen the commissioners approved an interim budget because not related necessarily to anything that's happening within the health and human services world, but mainly because I believe they're waiting on the legislature and the adoption of their budget, particularly as it relates to the education and where that budget will be. So the commissioners the preliminary plans are to adopt the FY15 budget on July 8th. Doing all the interim things that have to happen in the meantime to make sure that we keep our operations going during that interim. But we'll be able to do that.
Thank you, Jim.
Thank you.
Good report as usual. Thank you. Brings us to you have something else?
I'm gonna just kick off this next round
okay.
for Dr. Munger.
Oh,
And then
okay.
and then
Were you
introduce him.
worried he was gonna speak about that?
Maybe you speak about the issues that I have behavioral health, but not with my own issues.
Multi-talented.
We're gonna have a big panel involving, with, mental health.
I just wanted to take an opportunity. Dr. Rich Munger, who sits within the Health and Human Services Support Team, is responsible for putting this presentation and this group together today. Just as a word, Dr. Munger comes to us with decades of experience in the mental health and behavioral health world, both from running a state organization in Hawaii to being a deputy director in North Carolina and working with the LME before divestiture and working in a clinical setting within public health when we were doing integrated primary care with behavioral health involved in that, and brings to the table those years of experience and that opportunity to know best practice, to know what's happened around this country as it relates to behavioral health issues. And I would say that thanks to the support of the county manager and the commissioners and Mandy Stone, we were one of the more fortunate counties as the mental health transformation happened with the transformation from Blue Ridge to the current system that we have now. And with Dr. Munger's great help and leadership in working with the community to make sure that to the best of our county's ability, we've fulfilled and filled the numerous gaps that were left as a result of that. I can't speak highly enough about what Rich has done in terms of building coalitions and about what he's done in helping to help us with jail diversion efforts that you'll hear about today, helping us meet the demands that we have in the social work world for making sure that we address needs of abuse or neglect of children and adults, and his ability to bring people together and and have them get a shared vision for what this county needs to do has been an invaluable service to this county. And for that, Rich, we're very grateful to you and for the group that you have today. So thank you very much.
We're just going to start, before I even do introductions, we're going to start with a little 4-minute video clip, as you can see from Frontline.
You know, I didn't get your name. My name's Alex. What's yours?
Jesse Paulette from Corvala. On the other side, 3 courses, 450 degrees, molecule 3175 away from Luther.
Okay. Are you giving me directions?
Yeah, I'm giving you 5 minutes.
Okay.
Hey, Devon,
Yeah.
are you on medications that you haven't taken today?
Yes.
Yes, you did, or
No, I did not take.
are you out of them?
Yes, I am.
What apartment do you live in?
Apartment 18.
Apartment 18.
Yes, 1-8.
Very good.
Who do you live there with?
I stayed there by myself.
Okay. Do you have a phone at your house?
No.
Okay. If something happened where you need to get hold of family in an emergency,
Yes.
who would you call?
I would call,
Do you have a,
nobody really. I don't have any family right now.
do you have a brother or a sister or a mother or father,
No, I do not.
an aunt or an uncle that may be able to help you today?
No.
Where are you from? What city?
I'm from, I don't know, really.
Scenes like this have become all too familiar throughout America. As the nation's psychiatric hospitals shut down, Police departments everywhere were left to handle the growing number of mentally ill on the streets.
Watch your head.
I can't let you in. You guys are gonna kill me and all that. She thought we was gonna kill her.
What's your name, sir?
Why'd she think that?
You know she's crazy.
Husband was down on soccer meds. So you guys are just gonna do a voluntary thing there next year? She's set to go. She wants to go.
Once you had hundreds of thousands of people leaving the mental hospitals, they suddenly, obviously, didn't become mentally healthy. They went to the streets, they became homeless, and then they eventually began to cycle into the system that cannot say no.
Have you ever considered or attempted suicide?
No.
Do you plan to harm yourself now or while you're incarcerated? And
Well, most of them are nonviolent crimes. They're crimes against property, the petty theft out of the local 7-Eleven store, or even a criminal trespass. A person with a mental issue goes in there to try and get shelter from the elements outside, and they start acting up. And the property owner, calls the police, and then as soon as the police step in, they end up bringing them to jail, and here we go.
Today, there are nearly 500,000 mentally ill being held in jails and prisons throughout America. That's 10 times the 50,000 that remain in psychiatric hospitals.
I want to see the doctor to get my mask. Get out of my face, you filthy bitch.
This massive incarceration of inmates with severe mental illness has created enormous problems for prisons across the country.
There was a failure in society. There was no safety net for all of these persons who were no longer being treated by mental health agencies, and as a result, many of those persons who would have been in state hospitals are now in state prisons. So in addition to being the director of the Department of Corrections, I became a de facto director of a major mental health system.
Okay. It was interesting when I was looking for a clip to show you. We found this, and it's an old one. It's 2005 is when that aired, 9 years ago. And I went and looked back at, so when did we start to look at jail diversion as an issue? It was 2005 when I was working in the primary care clinic in the health department. And Mandy talked with me, talked to the sheriff and the major over at the jail about the needs around substance abuse. And we issued our first RFP in 2006. And RHA Health Services won that competition to station a case manager for substance addiction over at the jail. And so we have a panel here today to talk about where we've gone from 2006. We've come a long way. And I'm very excited and very privileged to have really the folks who are providing these services. Buncombe County, as you know, does not provide any behavioral health services. That's responsibility of Smoky Mountain Center. But we do things strategically with the funds that the county has allocated to us to try to fill gaps. And this is a gap, as you can see. Just imagine some of the numbers they cited, what they must be today, almost 10 years later, as far as people who are defaulting into the criminal justice system from the mental health system. So I'll be introducing folks as we go along. So let me start with Amy Griffith. She is the forensic director for RHA Health Services. And how long have you been with the RHA?
4 years next month.
4 years. She's a godsend, because when finally we got somebody who was going to stay and build this program, she has done exactly that. So I'm going to let her talk about our jail diversion services.
Thanks, Rich. Jim, that was a really nice introduction of Rich, too. That really summed up how we all feel about his vision and the way he works with this group to really bring these things to fruition. So I'm going to kind of highlight some of the things that he's done to help us get to where we are right now. Dr. Weigel, that was familiar, wasn't it?
Definitely.
We're sort of in this constant, like, can they go with you, Dr. Weigel, back to the hospital? No, they can't. So I'm going to let him pull up this slide here. As Rich said, Steve Allison was hired under the RFP in '06 to do substance abuse and jail diversion, and we still have Steve with us. We're really glad for that, but it's evolved considerably since then. We're now offering, we have a full-time jail diversion case manager, and if you guys are you familiar with that term? Everybody thinks it's like get out of jail, but that's really not what it is. It's a program that's targeted specifically to people, individuals with severe and persistent mental illness who wind up in the criminal justice system secondary to untreated mental health symptoms usually, but dual diagnosis, we know that. Most folks are dually diagnosed with substance abuse. So we've now got one person full-time doing the jail diversion. We've got 2 people doing reentry with the folks that we can't divert under that kind of a definition. And Steve is one of those 3 people, so we're lucky. This slide talks about sort of the 3-prong approach to diversion. Because outside of the severe and persistently mentally ill, we're also dealing with people with primary substance abuse, and that's where their problem-solving courts come into place. And I think last month I mentioned that there's the DWI treatment court, the adult drug treatment court, and the family drug treatment court. AOC the state cut all funding for the drug treatment courts across the state, and Buncombe County chose to pick up the existing drug courts that we had here. Does anybody remember that kind of history? So that was really fortunate for our county because we were able to keep a lot of people out of jail, out of prison, in the community working, supporting their families, and being in recovery through those 3 programs. The jail and prison reentry services, that includes the 3 folks I just mentioned, as well as our new contract through a grant that's really fun to administer from the Department of Commerce to help folks returning to their home in Buncombe County who from prisons get involved in safe and stable living wage jobs so that they can be stable and not go back to prison. And then the top one is kind of a special one to me. That's the crisis intervention team training. Is everyone familiar with that? That's that concept of teaching law enforcement about how to interact with people in a mental health crisis, hopefully stabilizing them in the community so they don't end up in jail. But we get really creative with that because there's a lot of people that still have to come to jail, but once they're there, we can do things with the magistrate. We're doing CIT with the magistrates now, and we're in front of judges, and so maybe they get arrested, but they're right back out into Neil Dobbins or the ED if Neil Dobbins can't keep them. So let's see, should we talk about the money? Can we talk about the money? Okay, I mean, it's hard to measure recidivism among a group of people that are so severe and persistently mentally ill, partially because it's hard to track how much they are compliant with the services once they get in the community. That's just hard for us. But we do the best we can. We can look at how many times they come back, though, in a given year, because these are our folks that are revolving back and forth, revolving through the door a lot. I think this was from 2012. So the outcome of looking at I think the 106 jail beds was tied specifically to our jail diversion program and our reentry program in the jail. Jail beds that's a kind of a fancy definition because the bed's already there and the lights are already on. But really we were talking about preventing the need for 106 additional beds to expand the capacity of the jail. Nuts and bolts though, that recidivism study in 2012 where we looked at a random sampling across those programs, prevented 1,219 arrests. So those are in 1 year, individual arrests that occurred, and which is huge. That's a huge savings. Because we're keeping beds empty, they can, the major's not here, is he? He can rent those beds out to other agencies that have overflow issues. So we're actually helping them generate revenue that they can fold back into the county dollars that are being spent. Anything else on this side? Okay, so.
Let me ask you
yes,
a question. On your officers that you train, are they just deputies or municipalities involved, like
That's a good question.
Asheville, Monterey, or what?
That's a great question. Our priority is Sheriff's Office and Asheville Police Department, but we pull from all of those areas. We're working closely with Smoky Mountain Center, which is nice because they can help us with these 23 other counties. But traditionally what happens is that we want at least 20 people to run a class. It's hard to get 20 officers off the street. So there's usually 4 or 5 seats, and we pull in from AD Tech, from UNCA. VA has talked about it, but they haven't sent me one yet. definitely the other smaller cities, surrounding counties, 911 operators can come from different counties. So we will fill it with law enforcement from any area or someone who works closely with law enforcement.
You have trained detention center officers.
Oh, correct, thank you. Thank you for saying that, yes. We actually hold special classes primarily for detention officers, and then we're able to pull folks from some of the other jails as well.
Well, and I don't want to take you off your message, but I did have an opportunity to go to drug court, and I attended their graduation, and it is now to get out of jail free program. I don't think I could keep up with the demands of staying in that program in terms of community service and staying with your treatment protocols, and then there were 4 graduates that day, and they all have to make a presentation, and every last one of them was just so incredibly moving. So thank you for that work, and thank you for funding that.
I'm glad you got to come.
Yes, and so was I.
Yeah, and the Family Drug Treatment Court is one that we work closely, that works closely with the department, with Child Services and Child Protective Services, and we're going to talk a little bit about that. It's a similar program to the Adult Drug Treatment Court, except it's not felony, it's civil. And but same thing, we've got these parents coming from DSS who are working their tails off to keep up with these court-ordered treatment things, but the end result is that maintains sobriety. I think I presented a case last time that with the timeline, that was from Family Drug Treatment Court, that success. So yeah, so this kind of pulls all those things together. And again, when Jim talks about Rich's starting with 1 person in 06, I don't have a pointer, but that was one of those in the middle under jail. And now it's all this. So that's a long way, and 9, thank you, 9 years. So yeah, so we have the drug courts over there. These are our jail station staff. And the newest leg, one of the newer legs, grew out of, resulted in this assessment center program across the street, which I think we've mentioned a few times. But let me tell you that started out as a substance abuse professional part-time doing assessments for DSS as needed to help determine if a parent had a substance abuse need. And it was real part-time, willy-nilly. It's now 2 full-time people, one of whom is Amy Johnson, doing nothing but comprehensive clinical assessments for parents whose kids are in custody with DSS, also for people who are released from the jail on pretrial release supervision pending their court date, and also for people that maybe come in front of Judge Young and she says, wow, I'm really concerned about you, could you walk down to the assessment center? So that's why it dovetails so well with these other programs, because it grew from being this one part-time service for DSS into this real comprehensive forensic assessment piece that I think is helping us. We're going to see dollar savings there because we're linking people more quickly. So they're not just floating around getting in trouble or ending up at the hospital or at ADAC or things like that. So anything else on this before I focus in on the parenting? Okay.
Amy, excuse me, where is the assessment center?
It's across the street in Heath Schuler's old office. We ripped that big eagle off the wall and put some clinicians in there. Or the seal of approval or whatever. Yeah, so it's perfect because literally they can be here with their social worker and he or she can say, you know, let's get you over to the assessment center, we'll do some paperwork, and then they can walk right over and then still make it back in time for their supervised visitation. So yeah, it's nice. Or from the jail, and sometimes we keep extra clothes there for people coming out of jail without shoes so they can walk around, get a t-shirt. So yeah, it's nice. And we're also right next to the family preservation. I think you heard last week or last month about that program with trauma-focused CBT. So they're in the same suite with us. And then sandwiched in the middle are the 2 prison reentry folks, the job placement specialists that we talked about. One of our trauma specialists, which is Christy Moeller, who's over there, she's now doing the critical incident stress management resiliency work with social workers, veteran services officers, and doing some military sexual trauma work with veterans in Buncombe County. So she's housed over there as well.
She's a product of the board meeting when we presented on veteran services, and the board said we really need to figure out a way to add that trauma-specific intervention for our veteran population. So, in case y'all think you don't make make a difference, you make a major difference.
Absolutely, yeah. This is a brand new project. It's really exciting. So, and it's going to be a huge success because she's perfect for this. So, if you have any questions for her after the meeting, she's in the green sweater. So I'm going to introduce Amy Johnson. She is one of the clinicians at the assessment center, and she's doing these targeted CCAs for not only the court system pretrial release, but also with HHS. And she's going to talk a little bit today about the assessment of these parents who come in, and if we're not doing something really actively, they're going to end up being in one of our other programs. If they're not already, they're going to end up in one of our drug courts, and that's going to be after doing some time in jail. And so we're looking at ways that we can intervene with the parents because they're kind of a captive audience when their kids are involved with DSS, and target some interventions to prevent this cycle. So with that, Amy.
I'm going to use the podium. That's okay.
I'll make your slide.
All right, and I tend to be a little soft-spoken, so please just give me like a little wave or something like that if you're having trouble hearing me. So I'm going to talk to you a little bit more about the assessment center, just go a little more in depth today about what we do. One of our primary tasks is to complete comprehensive clinical assessments. So these are individuals that were referred to us by CPS or the courts. These look at mental health difficulties, substance use, parenting strengths, limitations. And then what we do with that information is we're able to get a comprehensive report and get that back to the referral source with specific recommendations for services or interventions to help address these identified problems. So myself and another clinician, we complete about 41 evaluations a month. That average, they're seen within the week, and we are able to accommodate, as Amy mentioned earlier, getting people seen quickly, getting them in even some crisis situations where we've been able to get them in right away. So probably, I would say one of the most frequent comments or feedback we get about the services is thank you. Thank you for getting this back to us so quickly. On average, we're returning assessments within 2 to 3 days. And this allows people to get going on those recommendations and avoid unnecessary delays, kind of for everyone involved. So the parents we see on a daily basis, their lives have been filled with a lot of chaos and tragedy. And if you look at the slide up here, these just show some of the many themes that we see in their stories when we're talking with them. One woman, who for our purposes today, I'll name her Mary, she's just one of many. And she, throughout her lifetime, she saw her parents getting these knockdown, drag-out fights. By 15, she finally had enough. She left home, therefore left school. By 17, she was pregnant. And really, she met this man, and it was the first person that she really ever felt loved her. And to Mary, she thought, well, he at least apologizes when he calls me names. He doesn't leave as many marks on me as my father did on my mom. So here she is. She has no job, no money, no education. She's really struggling. She's using massive amounts of pain pills just to kind of numb herself from this daily existence. I'm sorry, I'm just recording here. So here she is now at 20, and she has a 3-year-old daughter, and someone calls CPS. And for Mary, she says to me, it's probably the best thing that ever happened to me. And I will say I don't always get that feeling from people, but it does happen actually more than you would think. And for Mary, she really didn't want to continue this life. She didn't want to, she wanted things to be better. She just didn't even know where to start. So these are really complex people, and this detailed and thorough assessments are really needed to make sure the right services are in place so they can, so Mary's 3-year-old daughter doesn't have to keep leading this same life, and that hopefully she can grow up into a healthy adult who may one day have kids of her own. One of the other things that we more recently have been asked to do is the parenting capacity evaluations, and this next year we'll be gearing up to do that and getting some added training. And so these are typically individuals that are referred by CPS. They might be looking at termination of parental rights, and some of the reasons that they might be referred are things like that they've had many failed attempts at treatment, that there's severe abuse and neglect issues that have been founded, or someone that maybe having such difficulty even taking care of themselves that there's really a major question on whether they can take care of a child. And so it has similarities to the detailed assessment that I already talked about, but that these just go a lot deeper and really take a look at the prognosis of this person being able to safely parent in the future. And so on average, too, we're able to return these within about a week, which is, from the feedback we've got, has been a much quicker response time than before the assessment center was in place. So to give you a little bit of an example, I'm going to have you turn, I think it's on the second piece of paper in your packet. The title is ABC Inventory Form 2. So it's not an actual assessment. It's actually just a few questions pulled from an assessment measure that we might use with one of the parents coming in for one of these evaluations. So if you just want to take a minute and answer those, I'll give you a few seconds. Good? All right. So anyone want to share maybe how they answered question number 2? I sometimes worry that I cannot meet the needs of a child.
Yeah, I would say that.
Okay, honest answer. Anyone else?
No. Yeah.
Okay.
I was worried, how many A's do I get?
There's no right or wrong.
Okay.
So they're pretty broad questions, but you know, one thing to think of is like, you know, think if you were married, you know, how you might answer this question, or one of these other people with all these things going on in their lives. And then, you know, if you want to make it even more complicated, then think about, would you even want to be honest? You know, because you know that maybe if you're honest, that you might never see your kids. You know, so these are just some of the many issues that we see and kind of have to work through and process through and you know, we know that parents have a right to be parented and protected and raised in a safe and healthy home. And we also know that when possible, it's best that they can be, you know, safely parented by a natural parent or, you know, family member. And so it can obviously be a very complex process, but one that's really important to these most vulnerable citizens of our community. And I hope you learned a little more about us today. And that's all for me. So thank you very much. Questions?
Show the slide about outcomes, Amy.
The one before this one. Sorry, I skipped it.
Yeah, this is the range of services at the assessment center. As Amy mentioned, it started off with us doing a few evaluations that were needed for child protective services, and it's developed this whole array of services. We don't have kind of outcome data we would like to have someday, but so far we're experiencing speedier resolutions by the court, faster caseload turnover, and quicker reunifications. That's anecdotal, and we are collecting data for the future. But the turnaround time, I think, Angie, am I right, is probably the thing that is social workers find so useful.
They love that turnaround time, and they can call and have a conversation with the therapist if they have an additional question about what the assessment said.
Angie, can you talk just a minute, or Katie, I don't see Tammy over there, about how that's different from if you had to seek that assessment through the traditional mental health structure, what that meant in terms of timelines for you all?
I can talk about it historically. Historically, what would have had to have happened is the parent would have to call the MCO and get a referral and then seek out a therapist and do all of that on their own. And then they would go to someone who didn't know sometimes the Child Protective Services system and the reasons that families were involved with us. So it was a very lengthy process in trying to help the therapist understand what it was we needed assessed related to safety of the child. And many times the turnaround time could be weeks. Now because we have the very close relationship with the assessment center, they understand our time frames, they understand what safety issues are. Ultimately what it does is help us achieve permanency for kids more quickly. And so that's the whole goal in all of this. And having those assessments gives us and the courts and the judges the information we need to move that family forward.
Can I add to that?
Please.
So there's sort of the process and the content, and the process that she's talking about is really key because systems are big and they're full of barriers just by the nature of being big systems. I think part of the content piece of this that she's touching on is that relationship. Also, the judges know these women now. They know their first names. They trust that the reports they're going to get are going to be thorough and in consultation with all the key parties. And I've talked with some of the judges who've said that there are certain people or reports or things that they see that they're not sure if they should trust. And that can really slow the process down. Another piece is the referral after the assessment. I mean, getting them in the door is really the magical thing. Because if I'm this parent, if I'm Mary and I'm said, well, here's a phone number to call, go forth and prosper, the chances I'm gonna follow through with that are pretty slim. And we see that, RHA has outpatient offices, so I see that our no-show rate's pretty high, but we can get them scheduled in the next day because we're not full of other stuff. But at the end of that, let's say we are successful in getting them in and assessed, then because we're doing this full comprehensive clinical assessment, Mary can say, you know what, I'm gonna do this. I'm gonna do this treatment that you're recommending, and I live next door to Family Preservation or October Road. It's on the bus line. I wanna go there. Well, we can send that CCA to October Road with their permission, and they can get right in the door for an intake. They don't even have to redo anything. So it really helps facilitate that follow, makes it easier for them to follow through on the stuff that they need. And I think that helps with the success too.
I think as the federal government, rightly so, put more and more requirements on timely permanence. If you're waiting 2 months for the evaluation, the parent only has 12 months for the court to say there's been significant progress towards reunification. 2 months out of that, waiting to even have the evaluation so you can then begin the referral process. I mean, we were literally seeing families caught against that wall in the courts because of process issues. It wasn't about their lack of commitment to have their kids come home.
My original conception of this was to provide evaluations for DSS. And, Angie had a different idea in mind in terms of what could happen over there. And this is the result of her vision, that when you look at the array of services, we have Smoky Mountain Center doing care coordination over there. We can do crisis intervention with DSS clients or court clients. They have psychoeducational transition to treatment groups. It takes a while for somebody to access care through Smoky Mountain Center. Of course, Christy's going to be there and also in the DSS offices, and we've got family preservation services in there doing trauma-focused therapy that you heard about last month. And the only reason any of that's available is because of Mandy, because that is prime space. And she, I'm sure, expended a few brownie points there to keep that space for us. And it is a wonderful space. And everybody over there working together, it is a marvelous opportunity to create a service which is very responsive to our clients. So that is, so you can think of behavioral health funding in the county as basically being in 3 pots. We talked about jail diversion and the whole continuum of jail diversion services. And then the assessment center, which also has a whole continuum of services. And the last piece is homelessness, which is a gap. And this is another system that people are defaulting into, especially people with mental illness and substance addiction, because services are not as available as they should be. And we're very lucky to have with us today the Executive Director of Homeward Bound, who many of you know, Brian Alexander, and he's brought Don Collins with him, who is also now working at Homeward Bound, and Brian will tell a little bit more of Don's story in a minute, but I will let you take it from there, Brian.
Thank you. Hello, everyone. So, Homeward Bound has not always been the way that it is today. 2006, until 2006, we've been around, I guess it's our 26th year. So until 2006, we were a traditional homeless service agency. We focused on basic needs, food, clothing, and shelter, and we were just trying to make sure that people were safe. And we saw a lot of the folks that Amy, both Amy's, we were talking about just a few minutes ago. But with the advent of the 10-year plan in homelessness, I hope that you all are familiar with the 10-year plan to end homelessness, as it is something that our commissioners in Buncombe County and our city council people in Asheville adopted in 2005. With the advent of that plan, which was really focused on ending chronic homelessness, which are folks that have disabling conditions, usually mental health or substance abuse, or both of those conditions, sometimes physical health conditions as well. It's really focused in on trying to work with that population in particular in chronic homelessness over that 10-year period since 2005. So we have about a year left on that plan. Last year in our point in time count, which is a count that we are required to conduct because we receive HUD funding from the federal government, our overall population has gone down a little bit in that time period. We saw a year-to-year dip, I think from, let's see, 570 to 533, which is a pretty good dip in a single year. Our chronic population, however, went down from 54 to 47 in 1 year, which is about 14%. But what's even more dramatic is what that dip has been since the beginning of the 10-year plan in 2005. At the advent of that plan, when that was adopted, it was 293 folks who were chronically homeless, and we're down to 47. So we've seen an 84% reduction in chronic homelessness in our community. And this is a population that was about 20% of our overall homeless population. We're well below that now. And we are saving the community money by doing that work. And that's done through, the Buncombe County is doing that by supporting efforts like supportive housing through Homeward Bound and the partnership that we have with the Asheville Housing Authority. You can see that we have housed 167 folks, and that says since 2006, but we actually started that program that partnership in 2010. We have an 89% retention rate, so people are staying in housing. And this is a lot of folks that, this is income-based housing. The Housing Authority, either through public housing or through Section 8 vouchers, this is the largest amount of income-based housing in our community. And so we were to a point at Homeward Bound when we had started our supportive housing program. We started going out to private landlords because we thought that public housing was just the worst idea for us to work with this population, because we know a lot about public housing. We've heard the rumors. We've seen the things on TV about public housing and how difficult it is. And so we didn't want to place folks with mental illness and substance abuse problems in public housing. But we had gotten to a point in 2010 where we were starting to hit a wall. We were starting to have a really hard time in our community finding the affordable housing at fair market value. We did not have enough funding for tenant-based rental assistance, and so we approached the Housing Authority, and the Housing Authority has been very open to working with us to prioritize the chronic homeless population. And so that placed them at the top of the list. We started moving those folks in. And what is really great about this is that it's not just Buncombe County. This is, I think, a model for the kinds of partnerships that we really need to put together in our community. It's not only Buncombe County, but it's the city of Asheville through the Community Development Block Grant funds. It's United Way of Asheville and Buncombe County putting dollars up for this program. It's Mission Hospital through their community benefits program to really try and face this head on. And what is exciting about this is that it really accelerated our drop in chronic homelessness in our community. We were seeing in 2010, from 2010 to 2011, I think we saw like a 30% drop in chronic homelessness, and that is because of that partnership, or all of those partnerships put together. And you can see on this the cost avoidance just last year, just by putting people into housing. It makes sense. Our 10-year plan on homelessness is based on the tenet of housing first, which means putting people into housing first and then giving them the kinds of supports necessary to to help them succeed. And in the video that Rich showed at the very beginning, the man that's in the ambulance, you heard them ask him the question about, do you live with anybody? What about your family? Do you have any friends? Do you have any acquaintances? Do you have any? And he said no every single time. And that's really what we face with folks that we are moving into housing, is it's really a lack of support. So it's not just about housing, but it's that support that goes along with that. And these folks also are in need of income, and a lot of them do have severe and persistent mental illness, and they do have substance abuse issues. And so that's where SOAR comes in through Pisgah Legal Services. And you can see how much is leveraged just in 2013 for the community. And then we also have Winches that is working with 50 clients a month for expedited entry to really have access to healthcare and to be not only physical healthcare, but behavioral healthcare as well. So one of the things that we have learned is that supportive housing does work. It reduces, based on those results, it really does reduce the amount of money that is going towards emergency services. With one of our first programs with Homeward Bound's Pathways Permanent Housing Program, which is our supportive housing program, we had a study done through UNC Chapel Hill, who came in and did a 2-year study with us. They looked at 2 years before people moved into housing and then 2 years after they moved into housing, really to compare how much money was being spent. And what we saw was that about 35%, there was a 35% cost savings after people moved into housing after those 2 years. People were saving about $3,600. So that's a significant savings for our community.
And Brian, we watched their arrests go from 40 in 3 months to 4.
That's right.
When they're housed.
Yeah, it does. It's amazing how much we see a huge difference in that usage of emergency services, because the job is providing support so that they're not using those emergency services anymore. They're not in the jail. They're not calling the ambulance. They are not using the emergency department. We're connecting them to primary mental health and physical health care. We're getting them connected to the kinds of addiction services that they need. So this is the Buncombe County homeless system. As you can see, there are 3 major components in the middle here. The Homeless Initiative Advisory Committee, which really is a joint commission of the city and the county. It is the advisory or the administrative arm of the 10-year plan to end homelessness. So they're the ones that are really looking. It's made up from members around the community, from the city and county, and they really are trying to look at the 10-year plan and drive initiatives and put funding recommendations in place for programs that are working and based on best practices. You have the Homeless Initiative Coordinator, Heather Dillashaw, who is based out of the city but paid for by both the city and county funds, who's overseeing that 10-year plan and really trying to drive systems change in our community. And I think that that's what we're really starting to see. And then we have the Homeless Coalition, which has been around for many, many years. It is made up of service providers, and they really are the service arm of things. They are the ones that are really trying to figure out what the gaps are, making sure that we're not duplicating services and that we're doing things based on best practices. And you can see the array of services around those 3 groups that range from shelter on up to physical and mental health care and behavioral health care, housing services. All of those things are absolutely necessary for us to be able to do this. This is a community-wide problem. It deserves a community-wide solution.
Ryan?
Yeah.
Your figures are amazing, really amazing. You're down to 47.
Yeah.
What wall or walls do you have? Why you still have 47?
Well, you know, we have an 89% retention rate, and the 11% of people that do not succeed in housing usually have a combination of mental health and substance abuse issues, usually compounded with physical health issues because of years of abuse. And so, and trauma, that's right. And so what we are trying to do is trying to figure out ways and interventions in our community that will help do that. One of the things that Homeward Bound did, we did get a SAMHSA grant, a Substance Abuse Mental Health Services Administration grant through the federal government, which was a higher level of intervention for supportive housing. That has helped. It is the program in our community right now that has that highest level of intervention in housing. It provides clinical substance abuse and mental health care in housing to people that we've housed, along with a housing specialist who's providing those tenancy supports. As the highest level of intervention and working with the highest level of folks that we moved into housing, it also has the highest rate of housing retention. We have about a 94% housing retention just by the fact of putting those extra services in place. But it doesn't end there. We know that we have in our community probably 30 to 40 individuals who have been through Homeward Bound supportive housing program. They've been through Project Rebound, which is that SAMHSA funded program, that we just don't have an intervention that works for them. They have a higher level of needs. And so one of the things that we as a community are really working on through the Homeless Initiative Advisory Committee is what we're terming a hard to house plan. One of those is through scattered site tenant-based rental assistance. Homeward Bound is getting ready to start working on a project called Extreme Needs, which for some of our folks, they're not going to be able to live in congregate settings, so that actually will begin in July 1st. But even more exciting is a project that we hope to get off the ground this fall called Oak Hill Commons. And I hope that you start here, if you have not heard about this, I hope that you start hearing about this. It is a complex that we, as a community, have put together a collaboration of folks that are trying to build a 30-unit complex specifically for kind of what we see as the way to end chronic homelessness. The hardest of the hard, those who have, that we've never been able to house because of their complex needs, or those who have not succeeded in our current interventions. And so we are gonna surround them on site with 24-hour security, which is a necessity for us in order to manage some of the behaviors that we have. We're gonna have on-site physical health care that will be provided through Mission Hospital. We'll have behavioral health care that will be provided at some level. Smoky Mountain Center is at the table, so we're trying to figure that piece out. And then certainly tenancy supports and housing case management that Homeward Bound will provide. We have a local developer, Biotat LLC, run by Ward Griffith, who has put together this complex. And it's really an exciting project. It is something that we are going to need all kinds of community support for in order to move forward. I think at this point we need about $325,000 more to actually make this work. Though the property is secure. They've already bought the property, it's secured. We've got Mission Hospital and Homeward Bound on board to make this happen. We just need the rest of the dollars to put up the building. So,
Brian, what age is your youngest client coming into Homeward Bound Services?
Well, we work with individuals on the chronic side. We do have some chronic families, but that's not as common. But we do work with families as well. So we have newborns, actually. We've placed people into housing, and they go from the hospital into housing. So I could stand up here and I could tell you a story, but we felt like it was actually much more important for you to hear the story from somebody who has actually experienced it. And so I'm really proud today to have Don Collins with us. Don is a former client of ours, and now he is a Homeward Bound employee. He works through our A Hope Day Center as a case manager and a peer support specialist. And he has an amazing story and has worked really hard to get to the place that he is. And he's a recipient of the support that this community has provided. So I want to invite Don to come up and tell his story.
be, I don't know, a bit nervous, but just kind of give you a little bit to where I was to where I'm at now. Of course, I was strung out on alcohol and drugs, and of course, you know, they leave you homeless, and that resulted to going to prison for period stints of time. So once released, I don't have family or nothing like that. So I do, but now kind of getting back, you know. So I was released from prison, and of course, couldn't go home, so I had to go back to the streets. Then, once released, I ended up going to AHO, which that's, you know, like I say, well, they had to go do an intake and all that. And so I ended up started back drinking, and so that left me, you know, still back on the streets. But each time that I went in there, you know, the individuals that worked for them, you know, they didn't look at me different for me. You know, I don't know, I'm sorry, I get a little emotional, but they treated me like somebody, you know. I mean, they allowed me to stay there because I didn't want to like go back for a few hours. I was able to stay because I was sort of safe, you know. So I eventually, like I said, I fell back off again, and I still go up young, and they still cared for me, you know. And I remember it was December 26, 2010. I think that was the last time I used alcohol or drugs, and because I heard one of the ladies, where she there now, you know, and she made me feel like I was somebody, and that stuck with me. From then I haven't like drank a drug or anything. It's been over 3 years, and 3 years, 5 months, and I want to say 22 days. After that, I mean, that gave me hope, and that motivated me to, you know, I am somebody, you know, regardless of what goes on, people do care. So, like I said, that motivated me to do the peer support specialist and whatnot, but, let's back up a little bit, sorry. So, I went to treatment, and after leaving treatment, I went to a transitional housing. And I kept in contact with them, and by the grace of God, you know, they didn't want me to fall back in that same crack that I was in, and so once leaving treatment, the halfway house, I ended up getting a job with Goodwill. So I worked for Goodwill for like 2 years. Well, yeah, I left treatment, sorry y'all. Left treatment, then I went to the transitional house, and during that process, I was at the transitional house, and I was kind of stuck, nowhere else to go. And so they provided me with housing, and today I'm still in that house. Like I say, just more of a motivation, and a kind word can save a person's life and change a person. So I went through the peer support, whatnot, because I wanted to give back, and they seen a dramatic change, and they helped me with a job, and to this day, it still allowed me. It helps me, you know, to help other individuals. So, you know, the clients might not realize, but they helping me also. So it goes both ways, and I'm truly grateful there to give people hope. And it's awesome. It is. So I think that's pretty much it. I've been sick for a little over 2 years. And I got caught back up in that cycle. And yeah. But yeah, I mean, it's a great organization to work for, you know, and it's just, I love going to work. It's awesome. Y'all should come up there. It's serious. It's awesome, but I'm grateful to be there. I truly am. Glad to be there. So that's pretty much it. Thank you.
Thank you very much. You have in your packet a description of all the services that are funded by the Behavioral Health Program. And this is the budget, just for your information, it's $1.8 million. If you're interested in the line item, it's on the back of the handout that you have, the one with the kind of rainbow thing on the front. We also included an example of a treatment plan that everybody walks out of the jail with, who is wanted services. Not everybody chooses to take services. And then the resource guide that everybody at the assessment center and the jail gets on discharge. It's kind of a mean guide to the services in the county. So I wanted to finish with 2 points, because that's what they say, that's all you remember, you know, when you have about a hour lecture. You remember 2 things, but I think you're going to remember Don, though. There's 2 things that are driving the system. Remember, it was 9 years ago, the sheriff said, gee, Mandy, I need some help over at the jail. A subsequent study a few years later, this was about, I think about 2000, what is it, 14, about 11, about 2010, professor at Western Carolina actually went in and did a study of our population, and he found that 2/3 of the women and 50% of the men in the Buncombe County Detention Facility have a substance addiction. Not abuse, because that's what he was studying, was being able to differentiate between abuse and addiction. That's addiction. 2/3 of the women and 50% of the men. This is what's driving the criminal justice system. It's driving much of the social service system as well. And then the lack of psychiatric hospital beds. And I just want to kind of end on that note. This slide is a little fuzzy, but those are public psychiatric hospital beds. You don't have to read the numbers. We've lost 2/3 of them in the last decade. 2/3. Now, the state will say, well, we're buying local beds. And that's true. Mission has a contract and funds some beds from the state. We have 170 statewide. Doesn't even come close to dealing with that. So full circle back to what we started with the ambulance, Columbus, Ohio. That's what we're seeing. We are closing down these psychiatric beds around the states. This is a national problem. And we just don't have the supportive services in the community. So that's why you see us focusing on filling those gaps with our dollars in Buncombe County. And I'm very proud to say, from the support that Mandy and Jim and commissioners have done over the years, I think we've built probably the strongest continuum for a county our size in the state, using county dollars, given the fact that this is not a county-funded system. This is a state-funded system. But the county has used its dollars very wisely to try and deal with these two problems which are driving the system. So we have a long ways to go, but that's why you're seeing what you see out there. Substance addiction, don't have enough places for people to go who are in psychiatric crisis. Rick, you want to add anything?
I don't even know where to begin. Just following exactly from what you were talking about, some of the data of the changes in the system. You're mentioning 2/3 in the last decade. Since the mid-90s, we went from over 1,000 state hospital beds at Broughton to 200 and some beds. So all those roughly 800 potential beds, they all filtered into our region. That's just our one region. Just like you said, the state will say that they pay for beds at Mission, but really that was just reimbursement for beds that were already there. In other words, that didn't create any beds or offset the loss in any way. It just helped Mission get paid for some of the work they were doing. And so yeah, it's a state failure first and foremost. And what I have been encouraged by more recently is certainly the work you're doing. The assessment center, I was very impressed by everything that is being done there, because frankly, since it started, I have not been aware of all the services that have already been created with that, and I think that's a great start. And I think, you know, now we're starting to have some bridging going on with Mission and with others in the community, because I think everybody realizes we have to get out in front of this, that it's been such that breakdown of the system has been such a deluge, and everybody's been feeling so reactive for the last decade. And I think it's just, with the steps you're taking and others, it's just starting the process of getting ahead of it. So thank you.
Thank you, panel members, very much. Don, back to you, Bill.
Thank you, Rich.
Thank you. I would like to thank the members of the panel. Thank you for what you do. This program has been an amazing process, and Rick, I'd like to thank you for the work that you have done to make this actually happen. Mandy was smart enough to say, well, I need Rick, and so we appreciate what you've done and what is going to be done. It's going to be interesting in a year as to how this all works out, I hope, because it is, what a challenge. What a challenge. And thank you so much. Thank you.
Thanks for having us.
Thanks for all the partnership. Thank you for sharing your story. I really feel a lot of courage, and good for all of us to hear that perspective. So thank you very much. I'd tell you two things probably on Richland County radar. Rich continues to drive us toward looking at, Rich can talk about it more than I, but an evidence-informed model around case management or FUSE and how we might fund that. It's very intensive case management for those hardest to serve individuals. And while we had issued an RFP for that in the upcoming year, we ended up going a different way because it required changing relationship with a current contractor, but we are examining how we might find monies and push forward with that anyway in 15, and I think Jim and I have found those dollars. And the second thing, which I think Dr. Weigel alluded to, is we're in conversations with Smokey about how we can build that assessment capacity, that walk-ins, that assessment capacity. And county owns property on Biltmore, both at 356 and 257, and how some shifts in those resources might help support that. So y'all be hearing more about both those things as we move. I agree. Rich has done a great job building partnerships outside. You know, I'll say things, sometimes we lose sight of what an integrated health and human service system gives us is the ability to leverage dollars across all of the DSS programs plus health. Much of what you saw Rich put up there is a combination of mental health funding and social work funding that Angie's come up with, because we're able to leverage those resources in a way that helps all those systems. And I don't want us to ever lose sight of that. That's one of the things this board's helped drive that puts us in a position unique to other counties in North Carolina. So.
Thank you all very much. And if you need to leave, you're welcome to do so, but you're also welcome to stay.
And take lunch. They didn't want to eat before they presented.
Thank you so much.
Thank you very much.
We're now to the point where we're going to, as the standard procedure, hopefully, is the advisory committee reports. And I don't see Ben, so Philip will tell us about the Economic Service Advisory.
Philip comes up, I'll share that Philip got asked to present on state conference calls for NC-FAST. The strategies that he and his team who are here have put in place around some on that side, working through the Medicaid backlog in NC-FAST, and are recognized as the urban county in North Carolina, the county in North Carolina, the urban's where all these numbers sit, who are moving through their Medicaid backlog the most efficiently and quickest, and are moving more Medicaid cases into the NC-FAST system by far than any other county in the state. And that is all about Philip and his state.
Philip, you straighten NC, you straighten it out. That's good.
Well, they caught the director of the state DSS called me at 9 o'clock one night this week, wanted to reach Philip. I said, Philip, I bet he's going to offer you a job. Philip reminded me both he and I have been there, and it's not worth it.
It's not, that's not about me, that's about our staff.
They are, yes, staff have done an amazing job.
As far as the advisory committee, just a couple of things real quick. We had a presentation from Rick Ellenberg about the transformation of the Employment Security Commission, which is not really the Employment Security Commission anymore. It's kind of workforce solutions in a lot of different ways. And one thing he mentioned that I wasn't really aware of is that you know, you cannot go into that facility anymore and apply for unemployment. You don't see a person to apply for unemployment benefits. Everything is done online or via the phone. And they have really evolved into more of a job readiness, job training type facility for not only individuals but for employers also. And it was quite an interesting presentation, and we think that there's some real correlation for us to work with our workforce population in the capacity of working with them in job training, HRD. We kind of refer folks now to lots of different places, but it seems that a lot of things that we refer outside to are now consolidated at one place. So we're going to work with them. We have a meeting set with them in the next couple of weeks about really making that happen, because I think there's some real benefits there for our clients. As I told you last month, we're really trying to evolve our Economic Services Advisory Committee into a solution-focused, issue-driven committee. And so last week we spent the time talking about that. I asked, because we had a number of people who have kind of come and gone off of that committee, we kind of started out with the purpose of the committee. And there is a charter from this board about the things that the committee is responsible for. Truth is, I looked it up. You know, provide input and recommendations to the board regarding the administration of our programs, recommend strategies to enhance access to services, identify and recommend strategies to improve our community partnerships. So things such as that. And that's really, as a committee, where we're trying to drive ourselves. We think that we've done most of the orientation about the resources that exist in the community, and we're trying to drive ourselves toward find out what those issues are and start to tackle those issues that we can bring to this board to address. So we did talk about the purpose of the committee. We also looked at who we had on our committee to make sure that we had the right folks on the committee. And as I said, over time, people have kind of come and gone from jobs. So we want to make sure that we have the right people there. And then I had asked them to bring back priorities next month. We didn't quite finish through this facilitated discussion. As you can imagine, there's lots of priorities that sit out there. What we really want to do is settle on anywhere from maybe 2 to 4. I'm thinking 2 to 3 priorities that we can work on, and develop subcommittees around those priorities, and let them meet every other month, and let the larger committee meet on the following months. The subcommittees can bring their issues back to the larger committee, and then we can bring to this board. So that's really where we're driving with the committee, the purpose of our committee, because we think if we look at our charter, that's what it says, that that's what we're supposed to be doing, and that's where we want to get to. So that's really, I'll certainly entertain any questions.
Thank you. Thank you very much.
Brings us to, we don't have Dawn, we don't have Gibby, so Stephanie.
Yeah, they decided to not be here today. Just so you know, Don Locke is celebrating 50 years of marriage, so if you see now, should congratulate him on that.
How many women?
Just one and a half. Just one. So Krista's helping me. There's a slide I want to put up on the screen to talk through the announcement that I'm going to make with you. But I was really delighted actually that Gibby and Don are gone and I get to get up here and talk to you about this. I don't know if you've seen it in the paper or seen it on Facebook, but we have something to celebrate that involves every person in this room. And it greatly involves the efforts of a combined Board of Health and Human Services. So if you haven't heard, Buncombe County is one of 6 counties in the nation that has been recognized by the Robert Wood Johnson Foundation for a Culture of Health Prize. Out of 250 counties, this is a year-long process. We've been selected out of 6. I'll tell you who else is in our ranks. I'm expecting more excitement. I mean, this is a big deal. So there are 6 prize winners from across the country, and they include Brownsville, Texas, Spokane County, Washington, Williamson, West Virginia, Taos Pueblo, New Mexico, and our colleagues down the road in Durham County. And so for a second, let's cheer, all right? And I want to talk to you about why I chose to use this slide, which comes directly from the Robert Wood Johnson Foundation. Because when we think of health, we often think of health as, well, we go up the street, and we go walk in Mission Hospital and we get health care. Or we go up the street and we walk into a primary care clinic and we see our doctor. If you really read the content around the Robert Wood Johnson Culture of Health Prize, it's much, much more than that. And so that's what's reflected here, and it's why we won this prize. We won this prize because this community is recognized for innovative and collaborative strategies that improve health. Now, what are the components that influence health? What's the smallest percentage up on the screen? 20%, clinical care. The actual access to care influences your overall health by 20%. So those of us that are healthcare providers, that feels a little bit like a downer, but you know, it's really not. But the reason I wanted to emphasize why this is very much collaboratively, this board, combined boards prize, is look at the social and economic factors. Education, employment, income, family and social support, and community safety. What did Rich Munger's group just talk to us about? All of that today. And that is 40% of what influences healthy outcomes for people in our community. And then our physical environment, air and water quality, housing and transit. The fact that we have safe places to recreate and be physically active. Those things are influenced by board decision making here and by our county commissioners and by our county, state, federal funding. Mainly our county, sorry. And then health behaviors, tobacco use, diet, exercise, alcohol and drug use, sexual activity. So I think if you look at this grid, I would hope that each member of this staff and each member of this community can see that this is a collective effort that goes from policies and programs to health factors to health outcomes. Those are the things that influence quality of life in this community. That's why I love to live here. I grew up in Eastern North Carolina. I'm not going back. My mother finally figured that out after about 20 years. But just so I don't veer off topic too far, I do want to talk about the fact that there have been over 70 organizations in this community involved in sitting and convened around the table in some form or fashion around the Public Health Advisory Committee. And that is incredible. To harness that much collaborative effort is fantastic. And then guided by the principle that every community, and I say every person, regardless of health status and resources, has the potential to improve and become healthier. Those are the guiding principles of this prize. And so here are the last bullets. Harnessing the collective power of leaders, partners, and community members, working strategically across the multiple factors that influence health that I outlined here, addressing issues that disproportionately affect vulnerable populations. Thank you very much for the panel today. That very much emphasized. You all have done such a beautiful job of helping me understand vulnerable populations that I really wasn't fully educated about in this community. Developing sustainable long-term solutions to shared community priorities, leveraging and maximizing resources, unified board, sharing resources, and measuring and sharing results. So, I have one call to action for you. and that is to mark on your calendar September 26th, because we are going to have a collective community celebration at the Wilma Sherrill Center. And I hope that all of us will be there. I hope you'll invite your family, your friends, your colleagues, because we truly do have something to celebrate in this community. So you can see why I was so excited that Dawn and Gibby were not here, because when am I ever going to get to stand up in front of you and talk about something so positive? So thank you.
There's no doubt about it, we can be very proud of this community.
I'm not moving either.
It's definitely a community effort, and we're glad that the health department will be a part of it.
Oh, by the way, Bill, I'm not moving either. Just stuck with me. I'm going to live here until I die, so get over it. Just thought I'd let you know. Yeah. Look at that face.
I sure am glad to hear that.
I know, I can tell.
Okay, Angie,
My
I believe
chair
you have
is-
you have some new people that we need to be introduced.
I do. Amy actually introduced her earlier. This is Kristen Muller. She is our new Resiliency and Veteran Services Specialist, and we're very happy she's here. She'll be working with our staff around secondary trauma across Health and Human Services, because we know that that is everywhere, and she'll also be a part of our community peer support group. We're very happy to have Christy and her expertise. So I want to talk very briefly about one of our child welfare priority areas, which is placement stability. And we have gone in Buncombe County, we've met the outcome. There's been months where we've met that and months where we haven't met it. And as you know from last month's presentation, multiple placements, if a child already has trauma, really contributes more to that trauma. So we believe that placement stability for kids is critical. So we're doing a couple of things around that. One is we're partnering with Mission Hospitals or Mission Health now to recruit within Mission for foster homes that can care for kids with special medical needs, but also to educate our current foster parents and help them get more comfortable with caring for some of these children. So we're very grateful for that partnership that's happening. Our Social Work Advisory Committee has really taken hold of this topic, and so our next agenda will be to brainstorm about recruitment ideas for quality family foster homes. We are also working very closely with Smokey MCO to make sure we have a good continuum for kids so that when they need to go to higher levels of care, those are available locally. And last but certainly not least is we have worked very closely with Lisa's communications team, who have done an amazing job developing materials for us for different audiences so that we can recruit quality foster homes. So we will be reporting back out to you after our year-long strategy to let you know how we fared with this outcome and with our strategies.
Angie, thank you for setting up the meeting for us yesterday. Candace and Kirsten and Jamie Shook and I talked about the trauma triggers and how we take that information that we learned last month and we help teachers see those trauma triggers in the upstairs brain and the downstairs brain. So we've got some good plans and we're excited about that. So again, one thing that we learned at this board meeting that we were able to carry out into our respective community.
It's one of those aha moments.
It was aha.
It really is.
It was. Thank you for bringing it to us.
Thank you, Andy. The next community advisory, we've got 3 people here. Frank, you the person that's going to report?
I think so. Terry, do you want to give just a brief update on when you spoke and met? I kind of talked about it last time, but anything with that meeting right before you left?
I don't remember. A lot has happened this month. That's
got a
why
lot
I'm
going on.
Other than I found out that I was wrong, one of the suggestions that came from the group was, why don't we just pay teachers with lottery money? Well, it turns out that was a good idea. I would love to do that again. It was good for me to hear those perspectives, especially that was kind of before I had actually gotten to the state legislature. now my head's in a slightly different place, so I think it would be even more valuable to do that. So I want to thank Lisa and Frank you for the opportunity to do that.
Did a town hall kind of setting for consumer and advisory group, and what a great opportunity for them to get to talk to them.
And I met some wonderful young people that were very enthusiastic and informed about their government and how it works. So
that just shows another program, because that's the CALA program that the county and the city fund together, and it's the City Academy for Youth Leadership. And those students, and Frank, you'll talk about that in a second, but they are amazing.
So we met the other night on Wednesday, and we're meeting every 2 months, and there were 38 people at that meeting, which is a huge number, and they were young students through seniors. I mean, it was well represented in terms of the community, and we had a presentation by the Asheville Buncombe Community Relations Council, and they talked about what they do, which was great because they went into the specifics about housing and your rights and accommodations, and people started bringing up issues, as they will. And it was a great forum because it was a way that we actually can see firsthand that if something is brought to an attention of, you know, an individual from the county or the city or the police even, is it followed through? One of the smartest comments was made by one of these CALA students. And I asked if I can use her name, and she said definitely. Her name is Lasha. And she was so brilliant because she was just like, you know, as a young person, if I bring something up that, you know, is bothering me or is an issue that I can't resolve by myself, and I go and ask help, and it doesn't get resolved, then that's it. I turn away from the system. I turn away from whatever it is. And so for me, that was just such a light bulb. I'm like, we have to follow through and make sure that we're connecting so that we get engagement back and forth. And I think that's just the key for everything that we do going forward, is making sure that we really do have those opportunities that are taken and presented to us, and we follow through with them. So, Lisa, do you want to add anything else?
Thank you all very much. Terry, I would like to say publicly how appreciative that I personally am that you chose to stay on this committee while going to Bali and getting all that stuff in your mind and so forth, but we certainly appreciate you staying with us.
Well, this is a wonderful way to stay grounded in what the job's really about. So I'm grateful for the opportunity.
Thank you so much. Okay, Mandy.
I'm going to be brief in director's report, but did think it's hard not to touch on following Frank's comments, what Don said about, I mean, if you really heard him talk about what changed for him, it's the belief that somebody cared, that people saw him mattered, and I think that's so much what our work's about. And that he felt like, you know, when he went back on the street and used drugs again and alcohol, that he found they still cared and they were still there. And I think that kind of perseverance is so much what we're about. And I want to say that because one of the things we talked about in executive board, and Bill's going to cover more of that, is I'm likely going to come to all the advisory committees and invite the executive board to come too, to talk some about the charter Philip talked about. Because we've moved from orientation, and we really need to start drilling into what we don't do so well and what those challenges are. We know there are areas that we are prize winning in. Behavioral health being one of those from NACO. Our community threat assessment team being an award we won this year. We'll do a presentation as a board on. And the diversity work. But there are areas we still struggle with. We don't always understand why sometimes our numbers are good and sometimes they're less good in terms of our child welfare benchmarks. We got to be willing to drill down in those advisories, look at our core services, figure out what those walls or barriers are that you mentioned, and get focused on not only what we're really good at, but where we're still struggling. And I think that's a conversation the executive committee and I need to have with each of those advisories, because there are core services we're responsible for where we are still struggling to meet mandates, or even, we don't even show so well against our urban partners. One we've heard about in this board is our immunization rates. You know, that we ought to be driven as a board around making sure we're up here instead of down here in terms of the 2-year-olds who have required immunizations. So I want us to be honest about that. I will tell you from an administrative perspective, there is an early retirement incentive in the county budget. Commissioners don't pass the budget until July 8th, but we are preparing for that. And in fact, Monday looked at our organization charts, and where we will be impacted. We'll be significantly impacted with that in leadership positions, middle management positions, and we're planning for, Lisa's done a great job doing open recruitment, because it is our plan for any of those line, social work, nurse, environmental health, economic service positions to have no delay when one person leaves and another person is training in that seat. Amy's done a lot of that work too, and we appreciate that. But Jim would have to help me. We have over 100 eligibles, am I right about that? A lot of eligibles in health and human services. So we're looking at all the potential and how that may play out. Last thing I don't have a total update for you on is space, other than we're still evaluating options and expect commissioners to make a decision around the Cox renovation or building a new building somewhere else sometime in the month of July, but we definitely have to deal with that space issue. We are working on our 2 new initiatives in the budget, which are the Comprehensive Domestic Violence Plan. We'll bring y'all a panel on that to talk about the components of that, the funding and how we're moving forward. And then the poverty remediation piece, we kind of took a step back and have issued a request for information. Rachel is issuing that. We're going to talk to the community about what our evidence-based models out there that community partners are already working on to deal with families who move in and out of poverty, and how might we invest that $150,000 we think the commissioners will allocate to us for that purpose. In a way that really makes the difference to those families in an evidence-based model. And how do we, the other part we're really trying to drill down to is how do we take all the things we fund and try to build those linkages across them. Now, if we're going to fund MANA, how can we help fund MANA in a way that helps those women struggling with domestic violence, or those men who are victims and are struggling with food security? How do we tie those pieces together is a lot of what Rachel and the foundation are focused on. Those are probably the main things I would share.
Thank you. One good thing that you're on my report is the fact that Jim and Mandy have already said everything we talked about in the meeting, so you won't have to hear anything from me. But yet we do have word of wisdom from Jerry Rice, the public person. So wisdom now.
Did you want to make that comment?
Well, I'm done. It's good to follow you, Bill. Put a little humor in it. Thank you, Mr. Chairman, members of the board. My concern is always about children in school. That's one of my biggest, and 26 years of observing, I see that it's still the biggest piece that we need to deal with. The things that we saw today, I congratulate Rich on, and I've followed it through the mental health MCO and all that. I've put my time in, and I think I know better than most where the gaps in services are. But I think there's some things that need to be fixed. I think this presentation today shows the end result and how to work on it. But it does not show the prevention. It shows the end. I'm concerned about the prevention and the beginning. And what I say that for is I think the school is the biggest vehicle that we need to work on in prevention. And it's being less worked on. We got new teachers, we got new resource officers, we got everybody new, but they don't have staff development. They do not have the committees in place, they do not have the staff in place, they do not have the medical in, the social work. All this is not organized in a manner that it's efficient or even workable. It's tolerated from day to day. One of the big things I'm going to share with you about therapy, they're fixing to move 400 kids from one agency into RHA. That's coming in July. There's no transition. It's just to dump this one in and dump this one out. Now, is that really something we need to be thinking about? what's that gonna do to the families and the children, and what's the repercussions of all that? My concern is that we need to have training for school resource officers, but we need the sheriff to do his training at the beginning when he gets new sheriffs in, not after they get it, but before. Also with teachers, and one of the biggest problems that we got today, and have had for years, is principals that don't have any knowledge and understanding of law, special education, medical, attendance policies, and things to do with kids that need help. Principals can say no to a lot of things because they don't know. But they say no to a lot of things that we really need to help them. So they need training. And that is something that we're going to fail in if we don't do something now. And I've already been to the school board. They have promised even 2 years ago to adopt a special education advisory committee for countywide. They ain't done it yet, and that's been 2 years. So what I'm telling to you is the school needs to be out front. You guys are doing an awesome job with what you got. But a lot of the kids, or most of the kids that are in your system, they're in the school system. And they got to be dealt with. So I think the school needs to shape up. And I ain't talking about just Buncombe County. I'm talking about all of them. Thank you.
Thank you, Jerry. Anybody have any announcements or anything? If not, do I have a motion that we adjourn?
So moved.
Moved.
When's not here?
All those in favor say aye.